My name is Ben Sherwood. I'm a consultant urological surgeon. I've been working here at the Park for the last 8 years. My practice involves primarily the management of urological cancers, mainly prostate cancer, but I also offer treatment for renal and bladder cancers. Together with expertise in the management of benign urological problems, benign prostatic hyperplasia being a good and common example. And I also have quite extensive experience in the management of other common general urological problems. With regard to my sort of cancer practice, clearly patients are referred with concern about the possibility of underlying cancer. And that can range from an abnormal blood test to a finding on self-examination, or a new symptom such as blood in the urine, which has been mentioned to a GP. And patients with those sorts of complaints are clearly extremely anxious and looking for a quick and comprehensive response from their specialist. Probably and increasingly the most common condition I deal with is prostate cancer, which is the most common male cancer in this country. Equally, we see a lot of people with other urological cancers, kidney and bladder cancer. It's very common for men to develop problems with their prostate as it enlarges through age, and that's another extremely common reason to come and see someone like me, is because of the development of urinary symptoms, frequency, for example, a reduction in the urinary stream. And just a sense that something's changed, and that can be extremely concerning and unsatisfactory for patients. For patients with suspected prostate cancer, then there are two sort of arms to the work I do. Firstly, it's the focus is on diagnosis or on the delivery of reassurance for patients who are concerned they might have prostate cancer. So a lot of that work involves physical examination. It involves the use of state-of-the-art imaging, such as multiparametric MRI scans, and also biopsies of the prostate. So that can be quite a considerable amount of the work that I do. Once a diagnosis has been achieved, then the focus switches to choosing the most appropriate treatment option. And at this point, it's extremely important that that's a tailored discussion to the individual, their age and health circumstances, and their attitudes and expectations from treatment. But the options can include surgery, for example, robotic-assisted radical prostatectomy, which is something I do an awful lot of, to radiotherapy or brachytherapy, for which I rely on the expertise of my colleagues in oncology. Ultimately, what you seek to deliver with patients who have a urological cancer is to cure them of their condition. And that remains the mainstay of what we are trying to achieve. But I think increasingly, with the development of novel technologies, we need to be able to deliver curative therapy, but without a disruption to the patient in the long term in terms of their function. So I think quite rightly patients expect now to have treatment, for example, for prostate cancer, but to be left with normal urinary function and increasingly with good sexual function afterwards. And that's a very important focus of the work I do.